Thank you very much. It's always strange when you hear introductions about yourself, and one of the things that it always reminds me of is why I feel so tired. You know, when you hear that list of things that you've done, it's no wonder I feel so tired all the time. What I want to do today, I'm aware that the audience is fairly mixed and eclectic, so rather than doing any heavy conceptual thinking and struggling, I thought what I'd try and do is give a little bit of an overview of a few things. So I'm going to start off by looking at where men's health and men's health promotion in the UK is up to at the moment, and where it's sort of travelled over the last 20 years. One of the things that I'm most proud of in my career to date is 3 papers that have all been in non-impact factor journals, but what they've done is they've mapped men's health promotion over a 20-year period, and as far as I'm aware, this hasn't been done in any other country. So the very first publication I ever did was about men's health promotion in the UK in '95. I did a 10-year update in 2005, and then I've recently done a further 10-year update in 2016. One of the things that I'm hoping over the coming years is that my younger daughter is just finishing her Masters in Public Health at the moment. So I've said to her that the next one will co-author, and then she can take the torch from that point, and it's up to her to carry it on. I suspect she won't, but I'd like that to be a legacy, it'd be great. So I want to give an overview of men's health promotion in the UK, then talk about some of the research that we've recently and currently been involved in. And then finally, if time allows, I'd just like to flag a couple of projects that I'd like to do. It's going to be interesting trying to find funding for them, as it always is, but I thought it's just useful sometimes to hear about maybe what next. You know, we all talk about what we're doing currently, but we don't always talk about what next. So that's the plan. So in terms of where things are up to in health promotion in the UK, what we've got at the moment is a situation where, as you can see here, the life expectancy gap between men and women is closing. So what we can say since the early 90s is that there's certainly been progress made in narrowing what used to be a very significant gap in men's health. Interestingly, I believe from an article that I read recently that globally that's not happening, which is quite interesting, and I don't know the details about why it's not happening globally, but it's not apparently. But in the UK it is, and I think in Canada as well, I think the gap is closing. Lots of possible reasons for that, some of which we'll talk about shortly, but still an awful lot of challenges. I think in the UK, what I can say is that in the 22 years now that I've been involved in the field, there's been a large increase in not only the number of interventions, public health interventions, trying to address health for men, but also, I would say, in the quality of those interventions. So in other words, there's been a lot of learning over the last 20 to 25 years about what does and doesn't work, and specifically what does and doesn't work for different groups of men. But that's only part of why things have improved, I think. So when we look at where these improvements are, this was some work that was done in Europe by my colleague back at the Centre for Men's Health and others. They did the first European report on men's health, and one of the things that came out of that was that an awful lot of the improvements that have been made over the age of 60, and half of them are to do with advances in cardiovascular disease. So is this really about public health interventions, or are the improvements actually more related to medical interventions than they are to public health and health promotion interventions? Is a question that remains, I think. There's also other aspects of medical care that have seen some of these improvements. You can't tell from this, but of the 3 areas that are represented there, so circulatory disease, cancer and respiratory disease, those improvements in all three have been greater for men than they have for women in the time period that's shown there, 2002 to 2012. And again, you'll see in the far corner, the cancer death rate is falling in the UK quicker amongst men than it is amongst women over the last 10 years. So as well as the cardiovascular disease, there's been better improvements related to cancer deaths for men. So I guess those are the good news stories in terms of advances that have been made. But what about the sort of challenges that remain? I think premature death clearly remains a big issue. You can see from this chart, premature death usually is taken as death under the age of 65. And you can see from the chart that that's, I was going to say significantly higher, but I'm aware that I'm in a room of quant people and that significance has a specific context. It's higher amongst men. Whether those are significant or not, I don't know. I haven't done any of the quant stuff. But you can see that premature mortality stands at about 28% for men and 17% for women in the UK. That was in 2012. I couldn't get any more recent figures for that. So there's a big difference in when men and women are dying that leads to that overall difference in life expectancy. And this, I think this remains one of the challenges. There's a lot of things sort of more sociologically that I think are tied up with this. They're not necessarily directly related to mortality, but I think they are related to health issues in relation to men, specifically in relation to men under 65. And the final one of these related to men over 65. So I think there's a lot of issues at the moment, and this is obviously being picked up in a lot of Western countries. Issues around declining manufacturing industries, young men in a lot of areas being ill-prepared for work in service industries, and then related to that, the effect of unemployment, and I'll talk just a little bit more about that shortly. There's been some very interesting qualitative work done around this in the UK, and the north of England is particularly hard hit because a lot of the manufacturing in the UK was done in the north of England, decimated utterly by manufacture and subsequent policies, unfortunately. And the qualitative work that's been done, mainly in Newcastle and Manchester, has been done quite recently with young men. So the impact of this is still being felt by young men, and a lot of these young men don't feel prepared for service industry type work. There's another interesting study that was done in the south of England, and that showed a qualitative study, and that showed a little bit of difference. The young men down in the south of England seemed a little bit more able to be flexible and adaptable. And I think there's also issues of social class involved in that, and we'll come on to that again in a minute shortly. I think in sort of middle age, working age, there remains massive issues around suicide, divorce, separation, job insecurity. So there's a lot of work around the impact of the gig economy. Is that a familiar phrase? Mm-hmm. Gig economy, the need to be flexible in working patterns and short-term contracts or zero-hour contracts. Do you have that phrase over here? So these contracts where there's no guarantee of any employment at all, it's a bit like agency working. They become very common in the UK. And I presume they become equally common in areas like the Rust Belt of the US. So I think these issues are not just related to the north of England, they're certainly common in other areas, I think. And then I think there's the obvious problems attached to ageing populations, living with chronic ill health, and increase in male caring. In the UK, there's now as many male spousal carers as there are female spousal carers. Yet a lot of men, the qualitative work tells us that a lot of men don't think of themselves as carers. So they are in caring roles, but not often accessing a lot of the things that people in caring roles can access, because they don't see themselves in that way. They're just doing what needs to be done as far as they see it. And then there's issues around isolation, and we know again from a lot of work that's been done that it's a particular factor for older men. So you've got some interesting initiatives like the Men's Sheds initiatives that some of you may be familiar with. They're only just sort of taking off in Canada. I've had the pleasure of being involved in some work with people over here looking at how masculinities play out in men's sheds, because they are just emerging here. So it's a good time to be sort of researching in that area and looking at who men's sheds work for, but equally who they don't work for, because nothing is a one-size-fits-all solution. So that's challenge one, issues around premature death and ageing. I've already alluded to what I think is a massive public health challenge, which is stuff around poverty and inequality. And I think one of the things for many years that was lacking in the men's health field was any comment on issues of social class and health inequality. Other than saying poor men don't live as long as women, there was very little else said about inequality and poverty. It's becoming more common to find research about it and to pull out figures, and some of them are very interesting. So in the UK, men in the most deprived areas have a life expectancy about just over 9 years, shorter than males in the least deprived, whereas for women the difference is only 6.8 years. Still significant. I can't avoid that word. I'll have to find another word. Still significant, obviously, still important. But there's a differential impact of poverty on life expectancy for men. And I think that's something that we don't really understand enough about yet. Not only that, but it's not really being recognised in policy at the moment, yet clearly is an issue. Sorry, I should have said as well, linked to that, there's also, we know from quite a lot of research in Europe, some of which in the UK, but some in Greece, and I think a pan-European study as well, that the impact of unemployment is greater on men from several studies that have been done. So there's a few things going on, and I would suggest that that's probably linked to male identities that are still quite wrapped up in work identities. So life expectancy isn't the only important thing. There's obviously issues around healthy life expectancy. And there's also a gender divide in healthy life expectancy. So you can see from this that the level of social disparity in healthy life expectancy is more marked amongst men than amongst women, both at birth and at age 65. So both life expectancy and healthy life expectancy are differentially worse for men. They have a greater impact on men. Challenge 3, I think, is one of the biggest for me, which is issues around mental health and wellbeing. We've seen already improvements in cardiovascular disease, cancer, respiratory disease, and there's other areas as well. Mental health seems pretty intractable. We don't seem to have made much progress in terms of men's mental health and well-being. So these are just a few things that were flagged in a survey. The survey is quite old now, but there are other pieces of work that suggest that similar things are still very much the case. So men are half as likely as women to seek help from the GP if they're feeling low. 45% of men compared to 36% of women thought they could fight off feeling down. Young men 5 times more likely than young women to take recreational drugs, twice as likely to drink alcohol. So there's all this talk about what's known as maladaptive coping mechanisms. So men, when they do come across stressful life events or mental health concerns, are more likely to engage in what psychology type people call maladaptive coping rather than positive coping. Less likely than women to talk to friends about problems or to family. So still some concerns. If anyone's interested in this area, I'd definitely recommend something that I only just came across 2 days before I came out here. So I haven't had a chance to read and put some of this into the talk, unfortunately. But if you want to look at this thing called the Man Box, some interesting survey work that's been done in the US, the UK and Mexico, really looking at the role of masculinities in all aspects of health, but particularly interesting stuff around mental health. So the outcome of all this, really, the ultimate outcome, or the ultimate concern, I guess, are the well-known issues around male suicide. So at every age group, it's approximately 75% male suicide compared to female. In the UK, for me, the really tragic story is that means 13 men a day, roughly, in the UK are taking their own lives. That's quite astounding to think of. And that's almost unchanged, certainly since the late 1990s. So no matter what we've done in terms of suicide strategies in the UK, they don't seem to have made any impression on these figures. Obviously, these things are never as simple as that. So if you look at the 4 countries of the UK, England has the best figures for suicide. By the best, I mean the lowest rates of suicide. Northern Ireland has the highest rates. Scotland second, I think. So there's a lot remains to be done in terms of men and mental health. Came across this report recently called Dying from Inequality, which is looking specifically about inequalities and the relationship to suicide. And one of the key things from that for me was that men in the lowest social class, living in the most deprived areas, are up to 10 times more at risk of suicide than those in the highest social class, living in the most affluent areas. So there's still a lot of unknowns. We know that women attempt suicide about 4 times more often than men, but men have 75% of all completed suicides are male. So there's something very unusual going on. If you read some of the stuff, you read the stuff from North America, they say it's all related to type of death, and they particularly draw on shooting deaths. But we don't have a lot of that in the UK. We don't have a lot of guns, so there are very, very few suicides by shooting in the UK. So it's more than just availability of things like firearms that are at play. Okay, how are we doing for time? We're all good. So, wrapped up in some of this then, you've probably already gathered I've got quite an interest in, I've put masculinity, an error, it should be masculinities, of course. I need to alter this slide, shame on me. These are the sort of common ways that masculinities are often presented, and certainly historically how they've been presented in the field of men and health and men and health promotion. So the simplistic reasoning goes, men have masculinity. Masculinity makes them take more risks or makes them more prone biologically to ill health, and therefore that's why they die more. Simple. Thankfully, in the last 20 years, there's been an increasing amount of work done that's sort of problematizing that overly simplistic view. You know, men are not just involved in fighting, violence, risk-taking. They're involved in an awful lot of other things. As I say, you know, half of the spousal carers now in the UK are male. Men are becoming far more involved in childcare, far more involved in the caring professions. So masculinity is not fixed. If I start talking about masculinity, I'll never stop. So I'll try and keep it very short. I'm very happy to talk to people more afterwards. But there's been a lot of work done from Connell's sort of key work on masculinities, which was 1995, she was talking at that time about understanding masculinities as part of a relational model of gender. In other words, masculinities are not character types, they're not personality types, they're not things that men possess, neither is femininity about character types, personality types, or things that women possess. What Connell argued was that they are found in what she terms configurations of practice. In other words, they only exist in their presentation. I'll leave that there for now, but they are basically sets of acts and actions, not things that live in here, was the fundamental argument. There's been some very interesting, more recent work. A guy called Eric Anderson has started to talk about what he calls inclusive masculinities, and he's suggesting that modern masculinities are very much changed. Men are no more concerned about being seen as gay. They're quite happy. He did a lot of work with college men. He was saying they're quite happy, even the straight guys, quite happy, sort of cuddling each other with physical contact. I think Eric Anderson goes way too far in the claims that he makes, and I'd love to take him out to some of the places that I go, because I do think that there have been some changes. I think things are shifting. I don't think that they've shifted anywhere near as much as Eric Anderson suggests, and the problem there is that if you believe what Eric Anderson's saying in terms of how you develop policy, then I think you'll struggle and you won't address a lot of the key concerns, especially around mental health and well-being, because that's linked still, we know from a lot of empirical and a lot of very good quantitative work, that that's still very much linked to holding fixed traditional views of masculinity. People that hold those views have higher rates of suicidal ideation, for example. They're less likely to engage in a lot of health promotion practices. So it's still out there. Yeah, I'll leave the masculinity stuff there, but I am happy to talk more about that. So I think there is a challenge, and I will return briefly to the challenge when I talk about some of the research that I'm hoping to do. So let's get on to some of the research that is either recently completed or current. And what I want to do is I want to go through 4 studies very quickly, but they're linked. So the first 2 are a program called the Salford Dadz work. That's completed now, but ongoing. I shall explain what I mean by that. And then that's moved into something called the Dadley Does It project. That's been a very interesting evolution. And then there's 2 that are slightly less linked, but still similar. And these are both exercise-related health promotion interventions, the Premier League Health and Men on the Move. So we'll talk about these as 2 sort of linked projects. These are some of the pictures from the Salford Dadz work. The Salford Dadz work is a project that aims to take a positive deviance approach to working with fathers. It grew out of a desire in an incredibly deprived area of Manchester to improve the health and well-being of children. And someone said, one of the things that we seem to be missing a bit in this jigsaw is work with fathers, and how work with fathers may help improve health and wellbeing for children. So the people involved in the work took what's called a positive deviance approach. So positive deviance has been, has anyone come across it as a concept? Susan has? Yeah. So positive deviance is an idea, and it's been used across a lot of disciplines and in a lot of pragmatic contexts. And it's about finding people, conditions, actions in a community that are different to the norm, but give the positive outcomes that you want. So one of the first times it was used, I believe, is a situation in the Far East, I can't remember where they were having a lot of child deaths from malnutrition. And instead of the researchers who were tasked with trying to solve this problem, looking at what was causing the malnutrition, what they did was they focused on the children in that community that seemed to be healthy. And they focused on finding out from the parents and those around those children what they were doing that was different. And it was quite simple. What those parents were doing was two things. One, they were feeding the little creatures that lived in the rice fields to the children, as well as the rice. And the second thing was that they had more frequent meals. So not necessarily more over the course of a day, but more frequent, and with the additional protein that came from the crustaceans. So both of these were not normal practices. These were deviant practices, but positively deviant in that those children survived. So practices then were spread, and I don't know that the problem was solved totally, but it was certainly improved massively. So that's an example of positive deviance. So the people that were working with these fathers in this area of Manchester, Salford, that's what they wanted to do. They wanted to go into the community. They wanted to find the guys in that community that were exhibiting positive practices in their fathering, positive practices in terms of meeting the needs of the children, and find ways with those fathers of spreading those practices. Really hard going. Really hard going. To start with, it was a 1-year project, and at the 10-month mark, I think they'd engaged about 3 men in 10 months. Those of you that work in public health or health promotion will know that these days you're expecting returns, bang for your buck, within 6 months maximum. You know, the flavour of the month, certainly in the UK, are brief interventions. Do you have that over here? So brief interventions for alcoholism, brief interventions, and they're usually 6 weeks, 6 to 8 weeks. So this is quite unusual, but I would suggest that the impact of this is far more significant, important than the gains that might be made from brief interventions. So they persisted with the work into year 2. They got, despite the poor progress, they got funding for year 2, and we carried on the evaluation journey with them. And what was achieved was just amazing. So the evaluation consisted of several bits, but because it was a positive deviance approach, we were very keen to make the evaluation what's called a participatory evaluation. So usually with evaluations we would be going in with specific measures. We might do pre and post measures. We might be involved in interviewing at various stages of the journey. The people that were trying to develop this work with the fathers said, we want you to evaluate the work, but you can't do any of that unless the dads let you and want you to. So it was like, I've never done an evaluation quite like this. It was like, okay, so you want us to evaluate it, but we can't take any measures, we can't talk to anyone. Okay, let's see how this goes then. So what we agreed was that as the work began to develop, the people that were doing the work, which were 2 people, 1 project manager, 1 community worker, who was a guy from the community, they would begin to gather some of the interview data for us. And if the guys were happy, they would do that by video, and it was recorded. So that's how we began. By the time they began to move into year 2, they got a few more guys involved. And what we did going into year 2 is we said we need to do a bit more than this then. So a group of 5 of the fathers came over to Leeds with the project manager and the project worker, and we sat down with them and said, what do you think success would look like, and how do you think that could be measured? So we gave the process over to them. That said, we did end up doing a lot of the usual things that you would expect. So these are some of the principles of participatory evaluation: driven by the community, shares responsibility for the design, data collection, etc., and sees the evaluator as a critical friend rather than a leader, which is very much the case. We have a very good relationship still with Salford Dadz. So we did end up doing what would seem relatively traditional evaluation, very qualitative. We had hoped to do some quant stuff, but we only got as far as agreeing the sort of measures that might be acceptable. By the time we got that agreement, we were too far into year 2 to actually apply it. But it was still important. I'll tell you why in a minute. So these were the data that were collected. The reflective diaries of the project manager and engagement worker were absolutely crucial in terms of the process aspect of the evaluation. Case study data from the dads, data from the children, and data from the women in the community. The stuff from the women I found most interesting of all. So this is some of the stuff from the dads. For those of you that are familiar with community health work or community development work and evaluations, it may not come as any surprise. But what it showed me, in terms of especially mental health and well-being, what you'd got, so the most significant sort of deviant behaviour that was identified, positively deviant, was the ability to open up, share, talk and communicate. Almost unheard of in this type of deprived location and community. This is the sort of thing that began to be spread through the Salford Dadz work. As you can see, this guy saying, real sight to see. Goes to show that men are sensitive, just not used to opening up. So a lot of things led into that. Obviously, the sort of settings where the work was done, the approach that was taken, the dads that were involved from the outset, and the tone and style that they adopted, all important, but all natural, because these were just dads from the community. And again, once I started engaging, it felt important for a huge amount of reasons. Being talked to like I was human. If any of you are familiar with work, especially work with young men from deprived locations, not being listened to or taken seriously nearly always comes out in research. They're just not valued. They don't feel valued at all. I felt important when I was asked to do some judging. So one of the ways that they launched some of the work about 6 months in was by having I think it was called a Dadly Does It competition. And the idea was just to get the children to either write things down or draw pictures of the things that they loved about their dads. And they got some of the dads doing the local judging of the competition as well. And they'd never been asked to do things like this. Massive thing for me. It's a responsibility. I needed that. Someone wanting you, someone needing you. They're just not used to being given responsibility or taken seriously. The impact on the children, incredibly moving, I think. I trust my dad more, I feel safer. I like spending time with my dad now. He's the sort of dad I always dreamed of having. Now I don't need to dream anymore. Amazing stuff, really. Something changed between us. We weren't good together before. Our relationship's better now. We spend more time together, do more things together. It wasn't so good before. So one of the things that the dads gained was a lot of confidence to do things with their children. They became far more confident in that, and obviously you can see from what the kids are saying, the kids loved it. It was almost like having a new dad. It changes people. My brothers are not as aggressive or mean. So again, these things are not just happening in people's heads. This is about sets, the impact on sets of interactions within the community. They do something different, like draw a picture, it really helps them. So different ways of coping when they feel angry or stressed. Makes a difference for my mum and dad because they're not being silly or aggressive. Makes their life easier. Makes my life easier too. I presume this was a younger brother who was getting beaten up by his older brothers a bit, by the sound of things. And this was an observation from one of the project workers. One child experienced problems with anger, which led to bad behaviour and lying to cover his guilt. As an alternative way to manage the situation, he agreed with his dad that they'd use a code word if he thought it was lying. This has been particularly helpful. He's far less angry since going. The main part of this project is 2 little contact times. One, a dads and kids club, and one, what they call brew and banter, just for the men themselves. That's it. They do other activities around it on an ad hoc basis. But this impact is just basically from 2 hours a week. What an impact from just 2 hours a week on these kids. The role of women, I think something that's very rarely been done when you're looking at the impact of health promotion interventions for men, is to look at whether that has any impact on those around them. And that's something that I'll return to if time allows, which I hope it will. So this was the situation at the end of year 1. As the dads grow stronger, the women seem to get worse and give them a lot more grief. Obviously, there are 2 sides to the story, but it does seem to be just because they're becoming stronger and doing things for themselves. Now, if any of you have been involved in evaluating the impact of, say, children's centre work on women, this is very, very common. A lot of community-based projects for women are very empowering. The women grow in self-esteem, they grow in confidence, and quite often that can lead to volunteering work, going back to college, and they grow away from their partners. It's not uncommon, but it's never raised and flagged as an issue. These women were flagging it. They were flagging it big time. They were not. Some of them were not at all happy. So the dads took this on board with the project manager and the project worker, tried to think about what they could do, and they did a couple of things. One was they developed a Facebook page, and I think over 3/4 of the activity on the Facebook page was actually from women in the community, interestingly. So that helped engage the women. And the other thing they did was that they thought a bit more about events that they were organising, and organising events in a way that it could involve the women more. So the women still didn't go to the brew and banter group, that was the guys themselves, and they didn't go to the Dads and Kids Club, but they went out of their way to do other community events that did incorporate and involve the women more. By the end of year 2, these were some of the things that were being said by the women in the community. A lot of these women were partners or ex-partners, but not all of them. Some of the women we interviewed were just people that were aware of the project and its impact. So this lady says, we talk a lot more now. In a way, we're doing it for the kids. Before, he'd come in and it'd be like, hi. But now we're communicating more. So it's one good thing. Considering we couldn't stand each other before, now it's let's all be friends. So a lot of women reported improvements in the relationship. And I think that's because the men were far more focused on the children than they had been previously. And again, this lady's saying everybody should experience seeing a group of men acting in this responsible, mature, supportive way, particularly women like myself who may not have seen that growing up. So in these locations, when the project manager and engagement worker first started, they asked people in the community, the men and the women, about the men in the community. the response from the women was very negative. The guys were either sat in the house playing on computer games. If they were out, it was because they were drinking or doing drugs. And this is the difference by the end of year 2 for what they'd seen from the men that had got engaged in the programme. So a couple of papers so far have come out of that work, but it's moved into another phase now. So they've got funding now to extend this into 2 other locations. Taking the same positive deviance approach and seeing if it can work elsewhere. One is a location fairly nearby. One is a location that's about 20 miles further away. Part of it is using the original Salford Dadz group as a living university. So the Salford Dadz have continued to exist. The project manager and project worker are not with them anymore. They constituted themselves as a council of dads formally, and they continue to do the work. And their skills and learning is now being drawn on in the other 2 locations. You'll be pleased to know, those of you that like numbers, we are starting to do just a little bit of quant work with the other 2 locations. Very simple pre and post measures, mainly using WemWebs. Those of you familiar with WemWebs, it's a very simple, I think 9-item mental health questionnaire, but also using something called Family Star Plus, which looks at different aspects of people's lives and sort of scores it on a star type thing. It's really made for working with people rather than for research, but it's easily converted because it's basically each one of those is basically a Likert scale. So the early thoughts are that it's very different in both of the new locations. One's been a real struggle, one looks like it's fairly straightforward. So there's a lot of learning about similarities and difference. 10 more minutes, Susan, is that right?
That's okay.
Yeah. So, Premier League Health, our English obsession with soccer. So this was 16 top English Premier League football clubs that were given money to do men's health promotion work. It perhaps wasn't very well thought through from a research point of view because they all did something different. And we were then tasked with evaluating it. So how do you evaluate something that's being done in 16 different ways? Basically, we opted for a sort of a lowest common denominator approach. So what we did was mixed methods. Quantitative stuff was very simple in terms of looking at smoking, drinking, diet, physical activity, and comparing it with national recommended standards for those things. And then the qualitative stuff was mainly interviews with the men and those who'd been involved in delivering the project. What I haven't said is that most English Premier League football clubs historically, it might be changing because a lot of them are getting new grounds, but historically they've been situated in quite deprived locations, and they all have a remit to work within the communities that they are based in. That seems to be a statutory obligation as part of being in the English Premier League. So this fitted in with a range of other community work that they were doing. It was exercise-based, but did impact on other behaviours. Some of the most interesting stuff was what they found was that behaviours quite often clustered. So it was very rare to find that these guys engaged in just one of those behaviours, like just smoking, but all the other things were really good. So most of the behaviours clustered. But interestingly, as you can see from this, they unclustered in not dissimilar ways. So even when the projects and interventions were not focused on smoking or drinking or diet and just had the physical activity element, they still impacted on more than just the physical activity component. And it's not insignificant in terms of the qual data that comes out. So it's a big motivating factor. It's been part of what's kept me off heroin and crack for 6 months. You know, these are pretty important changes in the lives of these guys that have gone along They're not insignificant. There's nothing better than feeling good about yourself. If you feel good, your confidence levels are high, your esteem's up, you're capable of things. So we didn't, unfortunately, collect data, but we know anecdotally and from the qual interviews with the people that delivered the programme, quite a few of these guys did move into volunteering. Some of them moved back into education, some moved back into work. So it had a ripple effect beyond just the unclustering of actual health indicators. I won't bother with that. That's a complicated process outcome model. But I was trying to look at how it was that it achieved what it did. That's in a paper. If anyone's interested, you can just email and I'll send you the paper. There's quite a few publications from the Premier League health work, as you can see. Men on the Move is not directly linked to this, but it's similar in that it's another physical activity intervention that I'm involved with. This is based in Ireland. And when I say Ireland, I mean the country Ireland, not the whole island of Ireland, so not Northern Ireland. And it's a pragmatic controlled trial, so certain elements of it don't fit into an RCT. There was not randomisation, for example, because in the real world you can't often do that, you know. And if you do, it becomes something that couldn't actually be put into practice in the real world, so what's the point? Nonetheless, it tried to stick as far as it could to trial type and design. So there's 8 local sports partnerships involved in 8 counties, which is quite significant. That's almost a third of the counties in Ireland. So it's pretty big, really. 4 intervention and 4 comparator counties. The 4 intervention counties have all done the programme now, and the comparator ones have just started it. Each one of those was recruiting 104 men across 3 different community settings, so the numbers are quite high based on power calculations. It was a 12-week programme. You can see there that it had various components, but basically contact, structured exercise twice a week, health information, various other things. And the quant measures were done at baseline 12 weeks, 26 weeks and 52 weeks. I think the 52 weeks ones have just been collected at the start of the year, I think. And you can see there what they were: height, weight, waist circumference, time to complete the mile, lifestyle behaviours, WEMWebs, and then a social wellbeing measure. And qual stuff as well. So focus groups with those delivering the service, and obviously interviews with men, and that was men that completed 50% of the programme, and also interviews with men's significant others. Again, the idea being to let's have a look at the ripple effect, not just the effect on the people going through the programme. Future research, I won't bore you with that one. This is one that I'd really love to do, the second one of these, gender masculinities in men's groups. So there's people in Switzerland that have done some very interesting work looking at the range of ways in which masculinities are discussed, deployed by people who are working in various men's groups. That's the underpinning model that was developed from the qualitative data. This is all in Switzerland, and that has been converted into all 4 dimensions of that have been converted into quant measures and surveys done to place these organisations within that sort of framework. I would love to do this in the UK. I'd love to replicate this in the UK. I think we've got quite a problem at the moment in the UK, in that there's been a bit of a vacuum in terms of who holds the men's health space politically. And what's happened is, sadly, the men's rights people have moved in big time. And I find that quite concerning. So I'd love to map this. And it would be a fairly cheap piece of work because so much of it has already been developed. So that's one thing that I'd love to do. I'm working with the people in Switzerland to try and put the bid together at the moment for that. And then the other one because it is my little pet obsession, is looking at how masculinities are used again and deployed, etc., within public health work. So I've been one of the early critics of people, practitioners, that don't think through how they utilise masculinity when they try and utilise it to engage and hook men into programmes. This is a very new campaign that's being run by Time to Change, which is a massive government-funded organisation in the UK that's looking to reduce mental health stigma, and they've got a very specific focus now on men, and that's just been launched, I think, in February this year, based around a boxing analogy. I would have bought the video. I've bought the video, I think, but I won't play the video because we've run out of time. But it's got three guys going to a garage. Their mate is there working in the garage looking fed up, and it all sort of converts into a boxing ring, and they're like in his corner. You know, they're all like supporting him and geeing him on. And I sort of said to the people that run Time to Change, I wish you'd have spoken with us before developing this, because there's a lot of issues with that. You know, one, not all men are engaged and interested in boxing. I am, personally, but certainly not all men are. If you want to take the boxing analogy further, there's always a loser. What do you do if your guy goes in the ring and doesn't win? You know, is that not worse for his mental health? If you're trying to G him up and he has to be a winner, that's what causes a lot of the mental health difficulties for men, feeling that they have to win. So, anyway, so what I want to do is try and do a discourse analysis of some of these approaches. I think we have got a lot of positive approaches. There's been quite a lot of interesting work done, particularly with African, Caribbean and South Asian communities, about utilising barbers' shops as a way of either providing health information or even engaging here in taking blood pressures and things. You know, so can specific contexts for specific groups work, and can campaigns utilise aspects of masculinities within those communities positively? Because like I said earlier, not all aspects of masculinities are negative. So can you draw on the sort of community values around barbershops, for example, in a positive way? I show this video so often, it is unbelievable. Honestly, if I showed you this, you wouldn't believe it. This is a young lady called Rachel Stevens. I don't know if any of you know her. She used to be in a group called S Club 7. And this is a video for testicular cancer. And that is a still from the video. And it gets worse. She rolls all over the bed. At one point, she takes a pair of plums in her hand. And I'm like, so what public health messages is this sending? You know, is this really, will it get blokes' attention? Absolutely, got mine. Will it get their attention for the right reasons? Will they remember the messages, or will they just think it was something to do with testicles, but wasn't she hot? You know, so really, what are we doing? How much are we actually thinking about how we use masculinities in health promotion campaigns? And then the other obvious one that's been done a lot, mainly in Australia, certainly in the UK, possibly here in Canada, I don't know, but utilising sort of mechanical analogies. So the pit stop health checks are literally that. The practitioners dress themselves in racing gear whilst they see the guys, and they talk about, you know, what's under the hood, and they have all these different car analogies for different bits of the body, which for someone like me who's got no interest in cars whatsoever, just wouldn't really work. But the other thing is, you know, how far does it actually make an impact on guys' practices? So I think that's it. So I hope that's been of some interest. I am very happy to take questions. I love questions.
Thank you very much.
Thank you.